Welcome to this presentation. We're looking at the paradigms that we use for recognising risk in ECG presentations for patients with suspected acute cardiac syndromes. In other words, patients that may be on that spectrum of having something between unstable angina and an ST elevation MI. Historically, it was the presence of a Q wave that alerted people to the fact there had been an MI. However, it's now recognised that ST elevation across a particular region or grouping of leads is a proxy for diagnosis of an MI. Unfortunately, this might miss anything up to 50 or 60% of the patients who are having an MI who won't show ST elevation in the initial presentation. The rest of this session is going to look at ECG changes that might alert us to these high-risk patients. So as well as the STEMI criteria, we're going to be looking at other criteria, including OMI criteria, that might give us clues to what's going on. The presence of a pathological Q wave is an electrophysiological occurrence that happens when an ECG electrode faces infarcted tissue. The easiest way to think about this is that the infarcted tissue acts as a window, and the lead is actually seeing what is occurring on the far wall of the heart. In other words, the view is through the window of the infarcted material to the opposite side of the heart. It's this electrophysiological principle that produces the negative movement that we see as a Q wave. And while a useful finding for establishing the age of our AMI, it's less likely to represent that window of time in which an emergent MI will respond well to revascularization procedures. The current proxy is STEMI, that is an ST elevation MI. Although it doesn't detect everyone that's on the ACS syndrome as having an event, it still misses a large number of people that would be thought to have an MI but don't display the STEMI characteristics, that group of patients that have been found to have non-STEMI AMI. Currently, the ambulance services in New Zealand are part of the national STEMI pathway. That is an overarching strategy for our entire public health system to shift people that are having an AMI to facilities where revascularization procedures will be of benefit to them. The current proxy relies on a very clear set of criteria that identify whether the STEMI is representative of an obstruction causing an AMI, and the procedures are written to reflect these criteria. You're expected to be familiar with this from your Year 2 studies, and so the rest of this presentation is going to move on to other criteria that alert us to high risk for an obstruction MI. We're going to look at this through the lens of a clinical desk inquiry where paramedics ask whether or not they should transmit an ECG to activate the STEMI pathway. Analysis of this ECG does show some worrying changes. Despite the wandering baseline, clearly there's some elevation in V2. However, there's not strong correlation with more than 2 millimeters of ST elevation across these septo-anterior leads, and therefore doesn't technically meet the criteria. We'll stick with this ECG and recap the worrying changes. The CPG suggests that ST elevation is required for a STEMI diagnosis, but other concurrent ECG changes can support the diagnosis. These would involve T-wave changes, evolving ST elevation, and reciprocal changes. Overall, this is a pretty good list and highlights a number of criteria that have proven to be pretty useful. The CPG goes on to say that in the absence of a clear diagnosis of STEMI, the patient must not be treated for STEMI without seeking clinical advice. The following sections in this presentation are going to provide information with which we might structure a clinical inquiry using ISBAR to seek clinical advice and a clear recommendation for action. The paradigm we're going to use is closely related to the OMI paradigm, or what's known as the obstructive MI paradigm. It's backed by a certain amount of research that looks at criteria above the STEMI criteria that may well in fact show that there is occlusion even though it hasn't produced what's considered to be classic regional ST elevation. There are 8 criteria that have been studied by Pendle-Myers et al. And we'll go through these as well as mentioning some of the other advice that's in the CPG. I've broken this list into 2 groups. One is a must-know list, which is essentially a STEMI equivalent. If these criteria exist, they are the ones that should be mentioned in the ISBAR conversation with clinical desk to see whether the destination to which the patient is going to might alter, that is avoiding a regional ED that has no nearby PCI facilities, or whether a discussion with cardiology may well be appropriate. I suspect that you're going to recognise most of what is on this list already, but we'll go into it in a little more detail. The first on the criteria was the hyperacute T-wave. I'll make the point now that the changes that are happening with obstructive MIs tend to affect the repolarization sequence to a greater degree than the depolarization sequence. Therefore, we'd expect to see any changes in the ST segment and T waves, as that's that portion of the ECG that covers the repolarization phase. So one of the first and most subtle signs may be regional hyperacute T waves. So these tend to be tall, pointy P waves that are disproportionately large when compared with the preceding QRS. And we can see in this ECG that there are anterior changes related to large T waves in relationship to the QRSs that are seen in V4 and V5. Another variation on the hyperacute T wave is known as the De Winter wave. Again, the anterior leads for this particular ECG show the typical characteristics of a T wave. So essentially we have a hyperacute T wave that's coupled with ST depression. De Winter waves are true De Winter waves as long as the terminal portion of the T wave is a positive wave. The next change that we're going to look at is whether or not there is a maximal ST depression in leads V1 to V4. And when we use this criteria, what we're describing is that if there is ST depression in the precordial leads, that the depth of the depression must be greatest somewhere between leads V1 to V4. In other words, if the maximum amount of depression was seen in lead V5 or V6, then the ECG would not meet this criteria. Maximal ST segment depression in V1 to V4 is very specific to a posterior AMI. So in this ECG we can see that the depression is very clear in leads V3 and V4, and we have some subtle inferior changes which make the ECG worrying as well. So in this case we could query whether or not the patient was having a posterior AMI. And certainly running this past clinical desk with that exact information at hand may speed up the process for the patient getting to reperfusion therapy. Another of the criteria, but we will look at this later in the course, is the modified Scar-Boser criteria. So all the criteria that we've used to date are highly reliant on the fact that there's a narrow QRS complex. If this is not the case, and the patient is in a left bundle branch block, the modified Scar-Boser criteria might help to determine whether, if not a new event at least, whether there's a concurrent MI with that situation. So, did the original ECG that the paramedics transmitted to clinical desk warrant further investigation? Let's go through the criteria we've discussed to date. There is ST segment depression with subtle changes in AVL. Generally speaking, ST depression does not localise unless there's an ischemic cause for this. So where there's a obstruction, it's very likely that there'll be reciprocal changes, as can be seen in this ECG with this very regional ST segment depression. We can see that there are in fact hyperacute T waves in V3 and V4. So there's at least 2 indications on this ECG that the event is an ischemic and an obstructive event causing an AMI. There are further indications that we might look at. In this case, we definitely have the subtle ST segment elevation, which has not quite met the criteria as laid out in the CPG. Of the other subtle signs that might be present, pathological Q waves are always an indication. In this case, there are none, and so it would appear that whatever is happening here is an emergent event. So, in terms of the paradigms that we've looked at today, many years ago it was the formation of a persistent Q wave that alerted people to the fact that it was an MI. The onset for the development of Q waves could often be hours into the evolution of the MI. So now it's a discontinued paradigm as it has no immediate benefit to getting people to urgent treatment. Instead, the proxy we use is regional ST elevation, meeting the criteria as laid out in the CPG. We know the onset of these changes is within minutes of the evolution of the AMI, and so it forms a very strong part of our current practice. It's very closely linked to our CPG and hence the national STEMI pathway. The last paradigm that we looked at was the OMI paradigm. There are various ST and T wave changes that we might look at, and research has shown that they are present when there is significant occlusion and benefit to reperfusion, even if it hasn't met the STEMI criteria. Again, the onset time is very early, within minutes. However, there's no current protocol or procedure, and hence we're not going to transmit and automatically initiate a code STEMI without further consultation via clinical desk and or cardiology. So, while these things are still under investigation and research and not yet incorporated into our guidelines, they may provide a useful guide and provide some very specific information that you include in an ISBAR conversation when you're trying to recruit help for a patient that appears to be having an ischemic event not yet meeting the STEMI guidelines. By way of conclusion, I just wanted to reiterate some basic points about any ECG findings. Firstly, that regionalisation is king. We know that 2 or more congruent leads is always a strong indicator. And maybe the next most powerful thing that would tell us that it's an occlusion MI are those reciprocal changes. And we use the pale mnemonic as a general rule of thumb to work out where we would expect to see these reciprocal changes. MIs evolve, so if there are subtle signs to start with, it certainly pays to take serial ECGs to find out whether the evolution is occurring or not. Just remember that the STEMI and the OMI paradigms require a narrow QRS for the interpretations to be appropriate. Where there's a wide QRS, you need to be looking at whether or not it's a left bundle branch block and then applying the Scar-Boser. Strongly recommend that you consult if you see changes that are not within the current STEMI guideline. The ambulance service has its guidelines written to match what's required for the national STEMI pathway for Aotearoa, and part of the way it's written is to prevent inappropriate activation of a cath lab. So, if the changes you see fall outside of the STEMI guideline, your role is to construct an ISBAR conversation and initiate that with the clinical desk. I hope this has been useful. We will go through this in a little more detail while we're on the block courses. But for now, ka kite.